Good afternoon, everyone. Today I will be presenting a seminar on rehabilitation in psychiatry. My name is Dr. Neal Kasbe, Junior Resident, Department of Psychiatry, CSSH and SMC. The content is we will be covering what is psychiatric rehabilitation, why is rehabilitation important, psychiatric rehabilitation and incorporation of person-centered recovery model, recovery, empirically based models of psychiatric rehabilitation, rehabilitation in the prodrome, acute and stable phases of SMI, early intervention and relapse prevention, continuity of care from hospital to community, stabilization phase, illness management, stable phase, vocational rehabilitation, recovery phase, cognitive remediation and community and occupational function, supportive education, sex education, comorbid substance use disorder, and end it with a summary. What is the difference between treatment and rehabilitation? Basically, treatment is any action that is designed to cure a disease and reduce its symptoms. So when we are talking about treatment, it is more about what the exact problem has been caused. Rehabilitation is any action intended to reduce the negative effects of the disease on the person's everyday life. It is more of a role functioning approach. We can take an example of a stroke patient. The treatment that we would give is different from rehabilitation. In rehabilitation of a stroke patient, we would try to inculcate various methods in which we will help the patient function properly in his day-to-day life. Whereas in treatment, there will be acute management and then later management. What is habilitation versus rehabilitation? Now, though these two terms are used interchangeably, habilitation is something that the person has not already learned. So if we have a person with intellectual deficiency, MR patient, and he hasn't learned a certain skill, we can use certain methods of occupational therapy to help him learn new methods. Whereas rehabilitation is the habilitation of certain lost skills. Psychiatric rehabilitation is restored to an optimal state of functioning. Now, how do we define an optimal state of functioning? The word optimal over here is very dynamic. Optimal state of functioning can be compared to the premorbid situation. Premorbid personality, we can reach the entire functioning, or we can even surpass, and the person's optimal state of functioning might even be better than his premorbid personality. Set of strategies and techniques designed to meet the needs of the person with psychiatric disabilities. This is CBR matrix, community-based rehabilitation matrix. This is given by WHO. This has 5 basic points: health, education, livelihood, social, and empowerment. And under that, there are various steps that we can take. Why is rehabilitation important? There is an increasing recognition that many psychiatric disorders need to be conceptualized as chronic condition with waxing and waning of symptoms over time, and that there is a need to integrate both medical and psychosocial approaches. It is essentially important for both the patient and the treatment team to identify targeted short-term and long-term goals that are operational and obtainable. We shouldn't look for certain goals that we cannot achieve. Plan a sequence of interventions and support that are appropriate to an individual stage of recovery. We cannot employ certain methods which we will employ during the acute phase into the stabilization phase. So we have to look at what the stage of the person is, and according to that we will decide what kind of support and intervention we will employ. Build in social and environmental support, stress inoculation, coping strategies, and other continuing therapies that will reduce the chances of relapse, and to continue a collaborative treatment milieu between the patient, family, and care providers that provide the greatest opportunity for mutual respect and decision making. So involving the patient, family, and other care providers is very important in psychiatric rehabilitation. Psychiatric rehabilitation and incorporation of person-centered recovery model. So the recovery model that we should come up with should always be centered around the patient. Individualized and collaborative methods of care improve the prospect for recovery. So we shouldn't have a blanket method which we will employ on all the patients. We should look at the individual and according to that decide what psychiatric rehabilitation method we will employ. The traditional view of the psychiatrist as the sole responsible and authoritative clinician has been replaced with the model, the multidisciplinary or interdisciplinary team approach. Like for example, we have a patient in the ward who has not moved from her bed since the past 8 to 9 months. We got a neuro reference done, we got a ortho reference done, we got various MRIs and scans done, and later we realized that in this we need to employ various multidisciplinary approach. So that would be employing physiotherapy along with other psychiatric medications. The person-centered approach is in line with a more optimistic vision for long-term recovery of the seriously mentally ill, as it offers opportunities to generate higher levels of motivation by patients. Recovery. Now, what is recovery? Recovery is sustained. Sustained recovery refers to long-term abstinence or remission of symptoms and normal psychosocial functioning. It refers to a measurable set of process, stages, and outcomes that are grounded on mediating and moderating variables that facilitate its attainment and maintenance. That is, recovery is an outcome of the process of recovering. Recovering is a continuous process, and recovery is the final outcome. Hope, destigmatization, empowerment, self-acceptance, insight, awareness, collaboration with professionals, sense of autonomy and self-control, and participation in self-help and patient-run programs. Empirically based models of psychiatric rehabilitation. These are basically models that have been tested out. Patients with most severe mental disabilities can gain from empirically validated behavioral intervention to improve their daily and community functioning. Evidence-based theories are now in widespread use in psychiatric rehabilitation. It is necessary that the full range of evidence-based biopsychosocial services be available in a continuous, comprehensive, coordinated, consumer-oriented, and competently delivered system of care. Rehabilitation in the prodromal, acute, and stable phases of severe mental illnesses. Effective treatment and rehabilitation of persons with severe mental illness require clinical services that are linked to the phase of their disorder. For most stress-related recurring and disabling mental disorders, the following phases are relevant for practitioners initiating or adjusting the treatment. Initially, we will do motivation and engagement in treatment. Then we will do prodromal phase, acute, stabilizing. Then stable phase will come, recovery, and then refractory phase. Prodromal phase. Early identification, engagement, and treatment are the mainstays of this phase, which may be associated with individuals who are at risk of their first episode of severe mental illnesses or are experiencing the warning signs of a recurrence of their disorders. The image that we see is basically what we are going to cover ahead. Symptoms of prodromal to a relapse. This is basically before a relapse what we are going to see. It is often the case that individuals with recurring illness does not recognize or acknowledge his or her symptoms. In this case, it is best to simply work on building a relationship with the patient that will eventually pay dividends for active treatment once trust has been achieved. If possible, prior to recurrence, the practitioner should provide illness management services that include training in recognizing and monitoring early warning signs of relapse, together with developing an emergency plan for preventing full-blown relapse. early intervention and relapse prevention. One component of illness management is teaching patients and their families to recognize the prodromal signs and symptoms of relapse, monitor them, bring them to the attention of the mental health provider, and follow through with their emergency plan to avoid relapse. Regardless of where a patient resides during an acute episode of illness, it could be home crisis, it could be a family home, it could be an inpatient unit, a partial hospital. The major task of the facility and staff is to mitigate overstimulation and provide a safe, secure, supervised, and predictable environment for the patient. This is accomplished by offering clear-cut expectations for daily activities, a posted schedule of daily events, discharge criteria, standards for each privilege level, and a structured routine and treatment environment. This is accomplished by offering clear-cut expectations. In this phase, pharmacological and behavioral treatment of acutely ill patients are predicted on stabilizing or eliminating symptoms and improving cognitive status so that the patient can move towards focusing on the development of skills and utilizing the social and professional supports that will help him move into the next phase of treatment. Most patients in the acute phase can begin learning illness management skills. During the acute phase, it is essential to customize skills training and support to symptomatic and cognitively impaired individuals. Thus, in educating, it is very important to use strategies such as motivational enhancement, repetition, responsive reading, modeling, role-playing, and problem solving. It is also necessary to be flexible in using relevant and culturally appropriate communication in educating patients about the value of medication. Continuity of care from hospital to community. Patients are rarely sufficiently stabilized by the time they are discharged due to increasingly shortened inpatient hospital stays. The patient is struggling with persistent psychotic, anxiety, or depressive symptoms after discharge from inpatient care. These symptoms, as well as cognitive deficits common in serious mental disorders, interfere with the patient taking the initiative to set up an aftercare appointment, a follow-up appointment. When hospital clinicians fail to involve family in psychoeducation regarding their loved one's illness and need for continuing care, family members may have mistaken belief that definitive treatment have been accomplished or completed in the hospital and fail to encourage follow-up services. Now, a lot of other medical illnesses, once the patient has a long hospital stay, oftentimes there is not a need for continuous follow-up compared to psychiatric disorders. That's why we have to psychoeducate the patient's family that they will need to come again for follow-ups and that the treatment will take a longer course. During the acute phase of treatment, some common patient responsibilities include such functional and symptomatic outcomes as engaging in independent self-care, personal hygiene without prompting, socializing with peers without hostility or social withdrawal, voluntarily accepting medication, and learning the reasons why medication are being prescribed, both for dampening the current symptoms that led to hospitalization and for later prophylactic purpose to reduce risk of relapse. The patient and doctor review specific behavioral program being made towards the goal on a daily basis, which is the cornerstone of motivation, hope, and shared decision making. The psychiatrist and other staff must ensure that the patient is familiar with and has a plan for reaching follow-up care as an outpatient. As discharge approaches, the responsible psychiatrist should reach out to the family and invite them to attend a psychoeducation meeting with psychiatrist present to answer questions and give feedback on how their relative is progressing. This can always be done on a daily basis too. Stabilization phase. As previously mentioned, stabilization of symptoms and cognitive deficits almost always continues after acute discharge into the stabilization phase. Most of the considerations noted previously in the acute phase are continued in the outpatient sector. Hence, the treating psychiatrist has the responsibility for ensuring that continuity of care is actualized. Whatever plans have been made in the acute phase we have to make sure that they are implemented in the stabilization phase. Stabilization of symptoms with medication. Once discharged, it is likely that the patient will stay on medications. Monitoring symptoms using quantitative scales such as the BPRS scales, the PAN-SS scales during regular appointment can help the prescribing practitioners make informed decisions regarding changes in type or dose of medications. Oftentimes, the reported progress, the worsening or improvement of symptoms might not. Responsiveness to medication is also affected by the emotional climate in the family, which needs to be considered by the prescribing psychiatrist. Illness management. During the stabilization phase, learning illness management skills, including gaining a more solid understanding of the role of medication, can be very useful. This includes skills such as how to communicate assertively with the psychiatrist about side effects or lack of symptom reduction. A lot of times the patient might not be trained adequately to communicate his own symptoms or the adverse effects. That's why we should help the patient develop skills in which the patient is able to effectively communicate about the side effects of the medication or the lack of symptom reduction or improvement. Supportive treatment sessions to the family or other caregivers to participate in the training sessions for illness management that focus on medication and relapse prevention. A lot of times, the caregivers, family members, they keep a record of what medications have been prescribed, what medications have changed, what symptoms have been noted. So a lot of time, sitting with the caregivers and their participation in the training sessions for illness management helps us train the patient better. Collaborative relationship with patient. Personally relevant goals are motivating for the patient's participation in the stabilization, stable and recovery phase of treatment. Currently, we have a patient who is a diagnosed case of schizophrenia, and the motivation that we are providing her is that she has 2 kids in the house and that she has to eat and recover and take her medications so that when she reaches home, she would be able to take care of her children. So that is also a type of giving her a relevant goal, which is motivating for her and is helping her in daily participation in self-care. The psychiatrist and other mental health professionals working with the patient must help the patient set incremental, stepwise goals that will bring the patient closer to his or her overall personal goals. These goals should always be divided into small steps and should look surmountable to the patient. The patient should not look at the goal and be like, this is not something that I can do. That's why breaking down of the final goal into small steps that are incremental and stepwise is very important. Each success that patient experience in moving deliberately towards their overall goals bring greater self-confidence, hope and positive expectations. Currently, the patient that I talked about who was bedridden for 8 months, she initially would not be able to sit on her own and would have to be pulled by other people. Now she's able to sit on her own and is able to dangle her legs by the side of the bed. So we have seen an inculcation of positive expectations in the form of her asking us that when will she be able to walk and how often will she be able to do the physiotherapy exercises. Because small goals were set for her and she has been able to achieve those small goals. These successes also reinforce the therapeutic relationship with the psychiatrist and other mental health professionals who are assisting the patient. As therapeutic relationship strengthen, so does the willingness of the patient to confide in their doctors. Involving families in stabilization. Because of the important role families play in facilitating or impending improvement in patients with major mental disorders, including schizophrenia, mood disorders, disabling anxiety, or somatoform disorders, it is vital for rehabilitation efforts to include them in planning, monitoring, and promoting stabilization. Relatives and other caregivers can be involved in sessions that are organized either for individual families or multiple family groups, with goal limited to psychoeducation or more extensively teaching skills in communication and problem solving, coping with persistent symptoms and implementing relapse preventing plans. In the stabilization phase, patients should be involved in family sessions as their symptoms and cognitive impairment permits. Multidisciplinary integration is accomplished most effectively through regular consultations and interactions among all those responsible for patient services. It is now well established that patients living with relatives who learn coping skills from behavioral family management have 2 or 3 times fewer relapses than patients who are treated with medications and case management alone. Stable phase. Patients are considered stable when their symptoms no longer interfere with everyday activities. Psychological interventions can displace symptoms as when patients are actively engaged in conversations or tasks that shift their attention capacity from isolated self-preoccupation by using eye contact, questions and answers related to the current and future plans and CBT. Incremental steps towards long-term person-centered goals continue in the stable phase. Progress towards goal can be promoted by participation in training programs that use behavioral learning principles to assure generalization of skills learned in skills training sessions that take place in clinical settings. The key to generalization is for clinicians, family members, or peers to promote opportunities and encourage as well as reinforce the use of skills in the natural environment. Vocational rehabilitation. During the stable phase and recovery phases, patients may be able to begin job seeking or return to school. Although supported employment or supported education is the most popular evidence-based service for vocational rehabilitation, it is not only the occupational goal that is clinically relevant. Before some patients are ready to work in competitive jobs, they inevitably need to transition through work-related activities short of regular jobs in the communities. At the same time, it is important to recognize the value of supported employment because patients with mental illnesses who gain jobs in the competitive sectors can work half-time or more in the competitive lines of work and can give satisfaction with their renewed or achieved status as workers. However, not all individuals with mental disabilities wish to participate in supported employment. We should always ask the patient if they actually want to work, and we should also analyze if their working will help them. Moreover, supported employment is not always associated with increased self-esteem, quality of life, global functioning, or reduced psychiatric symptoms. There are alternative ways to lead a working life, including an array of opportunities that can be viewed as pre-vocational in nature, such as volunteer opportunities and on-the-job training. When seeing themselves as self-directed agents contributing purposefully to their own patient-centered work goals, patients can make progress towards independence and self-sufficiency in a variety of ways as they are able to see themselves working towards recovery. Recovery phase. As noted earlier, recovery does not mean cure. Rather, patients in this phase are empowered to live meaningful and satisfying lives, having reached many of their overall goals that bring them into normal community setting and interaction. They are equal partners with their professional providers of service, making decisions and serving increasingly as their own case managers. They often assume paying jobs as peer counselors and peer advocates in addition to joining with mental health professionals as active proponents of public education and political action for decreasing stigma and providing and improving funding for mental health services in their state and communities. Recovered patients are capable of managing routines, work, school, and independent living, and illness self-management without direct supervision by relative or mental health professionals. That being said, it is strongly recommended that recovered patients sustain their connection to mental health services, even if this consists of only occasional check-ins with the treatment providers, given the increased vulnerability to relapse and stress sensitivity often experienced by individuals that have experienced severe mental disorders. Rehabilitation of social cognition. Social cognition pertains to the perceptions, beliefs, and interpretations of other people's behavior. Poor social cognition can significantly impair a person with SMI to appropriately respond to others in their environment. Social knowledge consists of understanding of rules and conventions that underlie social behavior and guide social interaction. Social perception. It is the ability to recognize general rules concerning roles and societal rules. Emotional processing involves the experience and use of emotions that have been linked with emotional intelligence. And attributional bias involves attributing causality to both positive and negative outcomes. Cognitive behavioral therapy. CBT is a type of psychotherapy based on principles of conditioning, learning, and cognition. As applied to schizophrenia, CBT engages patients collaboratively, challenging their interpretations of events or experiences. Thus, it is often used to assist patients in developing more realistic alternatives to delusion and paranoid thinking. In the case of negative symptoms, CBT is often used to challenge hedonic beliefs, schedule activities, and administer self-rewards for increasingly engaging in pleasurable activities. CBT works best with patients who are themselves willing to actively participate in the treatment, often as the result of distress from symptoms and or at least minimal insight into their abnormal nature of experiences. CBT as an adjunct to routine clinical care provides significant additional benefits compared with routine clinical care plus supportive therapy. In addition to problems uniquely associated with psychotic disorders, various forms of CBT are effective for addressing generalized anxiety, panic, social anxiety, depression, obsessive compulsive symptoms, and substance abuse. These problems often co-occur with chronic psychotic disorders, and there is no reason to believe that CBT intervention are any less effective in treating them in people with schizophrenia than in the general population. Illness/wellness management skills training. Gaining the ability to manage one's own psychiatric illness is central to the rehabilitation and recovery perspective. People learn about episodic and persistent symptoms of their illness, the relationship between symptoms and functional impairments, pharmacological means and other techniques, example breathing exercises, yoga, anapan for controlling symptoms, drug side effects, identification of warning signs of an impending relapse, and various other aspects of the disorders and its management. Behavioral skills indirectly relevant to the disorder management include, for example, the assertive skills necessary for dealing with the doctor and doctor's receptionist in gaining an appointment for a medication visit. Supported education. Supported education prepares people with psychiatric disabilities to achieve educational goals in an academic settings. Someone with a serious mental illness can get back to their education once in the recovery phase. It addresses ways to overcome obstacles related to achieving educational success, such as improving academic skills and problem solving, bolstering self-confidence, and engaging in career development. These may include assistance in accessing services which are already in place in the educational setting, help with locating and using school, social, and recreational services, preparatory coursework, case management support, ongoing support, and check-in meetings at the local student center, study support and visit to the campus library, linkage support to other campus services, and individual counseling. Sex education. Many individuals with serious mental illness aspire to and achieve meaningful education, work, and enjoy mutually supportive family and intimate relationship. The current impetus for increasing patients' sexual knowledge derives in part with the alarmingly high rates of HIV infections and AIDS found among individuals with serious mental illnesses. In psychiatric rehabilitation, implicit or procedural learning is enhanced by video and live demonstrations termed as social modeling. Some of the educational objectives that comprise more ambitious and enlightened efforts in this realm include the following: increasing patients' knowledge and comfort about sexuality, encouraging patients to identify and clarify their values and attributes about sexuality, informing patients about alternative methods of birth control, teaching patient decision-making skills regarding sexual activity, improving intimacy skills, imparting basic HIV and AIDS education, overcoming medication-related sexual dysfunctions and preventing deterioration or cessation of sexual activity, and instructing patients in the proper condom use. Comorbid substance use disorders. Substance use disorders have been associated with medication non-adherence, underachievement, decreased work production, poor health, neuropsychological impairment, social dysfunction, and violence, among other negative biopsychosocial effects. Comprehensive programs have frequently included not only standard mental health interventions such as medication monitoring and support services, but also assertive outreach to engage patients in treatment, intensive care management, and individual, group, and family substance use counseling. In summary, we are moving towards a more integrated model of care. Psychiatric rehabilitation today is an active, integrated, and person-centered enterprise with strong therapeutic relationship, trust, and cooperation between the patient, family, and multidisciplinary team. Excellent treatment is achieved by using state-of-the-art and empirically validated assessments. While neurocognitive deficits may pervade in many types of schizophrenia, person with bipolar or unipolar affective disorders may have less but significant impairment in this area. In some cases, comorbid substance use disorders can further impair already pre-existing cognitive deficits. Equally important is the accurate assessment of the functional capacity and, most importantly, real-world functioning performance. There needs to be continued emphasis on more integrated and comprehensive model of care. Patients deserve no less. Thank you. These are my references.